Hello, class. I finally got this to work. Thank you so much for tuning in. We're going to have a quick chat regarding calculus. So, as I mentioned before in the announcement, calculus will be our bread and butter. Calculus will be the thing that we'll spend so much time removing from the patient's mouth. And at this point, you might be wondering, like, what's so wrong about calculus that we spend so much time removing it? Okay, so we're going to learn what is it that calculus has that interferes with the health of the patient. So we already talked about pellicle. We went through the progression from pellicle into biofilm and then into more concrete and bulky forms of deposit, such as materia alba. And now we're going to go to the next level. So this is biofilm 201, calculus. So what we have is mineralized biofilm. And the factor here and our variable is time and removal. Okay? So in order for the calculus to occur, we have to have the neglect of the removal of biofilm. So we have this biofilm that mineralizes, and we're going to talk about this like how? How do we mineralize this? Like, what's this magic? The magic is in our saliva. We talked about our saliva, which is a thicker substance, right? It's liquid, but it's uh, full with minerals. And out of those minerals, the most predominant one is calcium, hence the name calculus. Okay, so that's your calcium present, plus other minerals that will be bathing that biofilm and creating harder substances. And these substances are formed with crystals. They can form on other structures other than natural teeth, and we have seen this in hard water deposits. We have seen this in the ocean, in the form of barnacles. But in reality, in our mouth, we can have calculus on anything. So we can have calculus on your partials, you can have calculus on your implants. It's not as common as it being formed on the surfaces of teeth, but it happens. So for calculus, just like biofilm, we have supra, which is above the gum line, and we have sub, which is under the gum line. The calculus itself is like a rock in the garden. I like this analogy and I use it often with patients. You see a rock in the garden, there's nothing wrong with the rock in the garden. It's slimy, maybe, if you've been there for a while. But the significance is when you pick up that rock and it has been there for a while, you're going to find a bunch of little roly-poly bugs, spiders, all kinds of things. It prevents from water to wash things away, and the same happens in our mouth. It makes it difficult for us to access under those rocks, calculus. It must be removed to regenerate lost or damaged tissue. Also, it propels an immune response. So we're going to think of a big, big splinter in your finger, right? So the splinter by itself is just a splinter or a little spike of metal. But what the body does in order to get the thing out is super harmful, like if it's not removed promptly, is the inflammatory response. So we're going to have swelling for the patient. And we have behavioral factors versus systemic conditions for the calculus formation. We'll talk a little more about this. And we have the calculus formation due to high levels of calcium and phosphate ions in saliva. That will be a systemic condition. But for behavioral, it could be things that the patient is eating that are very sticky and that the patient is not removing. Let's talk about some important factors. Alkaline environment is not restricted to one bacterial species. We talked about this, our oral microbiome. Not all biofilms mineralize. So patient can have some biofilm there forever, could have some inflammation, but it might not become calculus. Mineralization usually occurs in the matrix, but eventually spreads to include the bacteria. If you remember, the matrix in the biofilm will be that squishy, flubbery substance that binds everything together. So this is what we're talking about here. Normally, the calculus will be that slimy thing that calcifies, but eventually it will spread to the bacteria that's inside the slimy matrix. We have our supragingival calculus. We have it right here. I want to welcome you to the rest of your lives. We're going to be removing the supragingival calculus on the inside of the mandibular anteriors forever. This is the most common area where it is located. I think we have talked about this a little bit. Where there's an abundance of salivary ducts, there might be more of an abundance of calculus, right? These are areas where the saliva is coming out, shooting out of the ducts with all of its minerals. And in this particular area, it's going to stay puddled for a while, okay? And this happens especially when you're sleeping. We have it also in the crowns of teeth, out of occlusion or non-functioning. And we have it in the surfaces of dentures, dental prostheses, and oral piercings. Pretty much anything that sticks out and has texture. Now, this is something that you will be finding and encountering eventually, your supragingival calculus that is completely enveloping the mandibular anteriors. This is an extreme case. If you start thinking about this, the way this will be looking in the gums of the patient, you can imagine the extreme irritation, right? The supragingival calculus is going to be more white and more chalky, like we see it here. Now let's think of something. The destruction that something like this can generate, right? And just the same as the biofilm, things are going to be growing upward and then they'll start going downward. So when we start having this calculus like going into underneath the gums, it starts pushing and pushing, and more microorganisms get underneath, more and more and more. The thicker the layer of calculus, the harder it will be for the patient to reach those areas. So it creates quite a bit of destruction. On a patient that has something like this, when you remove it, guys, you might expect to find a lot of bone loss underneath, and even at times a good amount of mobility. To find the calculus, the supragingival calculus, you're going to be seeing it with clinical examination, and for the little residual, like just chalkiness after you have removed everything and you want to check that everything is nice and tidy, you can use air from your air water syringe. Now let's get into the subgingival calculus, which will be the same as the subgingival biofilm. You're going to find it apical to the gingiva. It could be generalized or localized. We're going to find it a lot in between the teeth. So with calculus, the key, and you kind of start seeing this trend, is that it will get stuck where it can get stuck. So you're not going to see, normally you're not going to see a lot of calculus in the front of the teeth, right? Because it's super slippery. Our enamel is slippery, like it's really a little harder to deposit on the front of the teeth. But in areas like the anteriors where you have a real nice CJ, maybe gingiva that is sticking out, right? That is open, retentive, there you go. And the same in between the teeth. So these are corners that are going downward, that are little triangles, perfect area for the saliva to puddle. If you have food in there, we all have food in between the teeth, right? So these are preferred areas. The subgingival calculus will be occurring with or without associated supragingival deposits. So this is important. Not every time we have subgingival calculus, it comes from supragingival. Sorry. Sometimes you're just going to have it down there because of suds and foods, or even a little speck of mineralization that occurs under the gum is going to start giving way to more and more calculus, subgingival calculus. Now, the subgingival calculus is 60% mineralized. So we're seeing these things that are harder. They're more tenacious, they're harder to remove. And then we're going to see a change in the color. So it's not going to be white and chalky anymore. It's going to be gray to black, brown, dark yellow. And the subgingival calculus is derived from the inflammatory exudate in sulcus and perio pocket. So you might have the debris and it gets covered and bathed in that exudate, right? So let's think about this. Yes, the saliva we have an influence on this one, but also those exudates. So the origin is a little different. Now for the subgingival examination, we're going to do a visual examination. How? You say, Dr. Z, you can see what's under the gum. Oh, but the tissue can feel it. So you can see inflammation, you can see redness. And then if you happen to stick your probe in there, lots of blood. The tissue's not liking the calculus there. We also have radiographs, and we're going to see lots of examples of these radiographs or visible calculus. And then we'll have your tactile examination with the probe and explorer. You have enough subgingival calculus, the probe is going to get stuck. And so this one is a combo. Supra sub, we can see the supra clearly, very visible, and we can see the inflammation in the gum. Okay, so this is a mixed bag. Now we see here, there's calculus and there's stain, but there's also stained calculus. And unfortunately, anything that makes the teeth rough is going to be super attractive to both calculus and stain. So you're going to see these situations. I just told you that it's not very common to have calculus in the buccal of the tooth, and not in the lingual either, really, unless you have been creating stain there. Then the stain is going to be retaining the calculus. If anyone knows a little bit about tiling, we're going to need a surface that is a little rough in order to put our tile glue. This has to have a name. In order to put our cement, I guess, we want to have a surface that is porous so that it can attach, right? So right here, the stain is creating that porosity. And then we can see the inflamed gums. So these gums are pretty darn inflamed. So which tell us that something is underneath. We have this inflammation here. You're going to become well acquainted with this. So clinically, you can tell immediately there's calculus in there, those gums, even if you don't see calculus supragingivally. What else do we have here? Okay, we're not too familiar with this just yet, but you can see these chunks in here. So I will show you in the, even here, you can see this is the way the tissue look normally, nice and smooth. Maybe this is the only area, and then even then it's questionable because it looks a little fuzzy. And then you start looking on the other side. There's little clouds. There's a little blob. There's an actual chunk in here. There's an actual chunk in here and another one here. Okay, and something that's interesting about the calculus deposits that have been there for a long time, fellows, the bone loss is going to match the shape of the calculus. Is really crazy. So you see here, this has been there forever. You can see this chunk here, and you can see the shape of the bone going up and matching the shape of the calculus. But you see the calculus being so far away, right? The calculus is here, the bone level is here. Remember, the bacteria, they're going to create colonies that match the shape of the calculus. So we have a little roof for the colony. So the bacteria is going to deposit underneath to be nice and protected. And you're going to see more examples like this as you advance more in your professional life. We have here lots of bone loss in this patient. We want the form for the bone to be up here close to the CJ, lots of bone loss, and we can see calculus here. So you can see the little chunk right here, and that corresponds to the bone loss. As a rule of thumb, fellows, once you start seeing patients, you're going to realize that the calculus that you see radiographically is the ugliest calculus that you're going to see in the mouth. What am I trying to say with this? When a patient has radiographic calculus, something like this, you'll be looking at like, oh, he has one, two, three, four pieces of calculus. No, 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 no. Mm-mm. Not all calculus shows in radiographs. So you're seeing only the ugliest, meanest, and most dense of pieces, but the mouth is full of calculus that is not so mean and so dense. So you're just seeing, when you see radiographic calculus like this, you know that you're going to have a lot of calculus everywhere. Okay, so this is another example. So this will be supragingival right here, white chalky, and then you start seeing how the color changes, and you see this poor tissue asking for help, right? And it's the real beautiful thing of caring for the patients and seeing them again, having the opportunity to see your patients that you have treated, is that the next time the patient comes, the tissue is not going to look like this. The tissue will be nice, pink, and even tighter, and probably not so much higher all by itself, but it's going to look beautiful and healthy after you remove the irritant, okay? Much like removing a splinter from your finger. We have other examples. As I told you, this is evil stuff. You can remove it, but it's going to take you a while. And it means that you have calculus everywhere else, just not all of it is as dense as to show up in the radiographs. But you can see the corresponding bone loss whenever you have calculus like this. It has been a while. So we have bacteria depositing and um, wreaking havoc and destroying bone. And right here, this is a real sad example. So we have this big chunk in here. The bacteria made their home right here. And I'll tell you guys, this tooth is probably gone. This is probably like a rest in peace type of a thing, like by a real crazy miracle, we might be able to remove this and graft, but it's real difficult. So we can see how calculus can harbor all this infection that will be destroying the tissue around the tooth. So the composition of the calculus, we have inorganic composition. So this is a rock, pretty much. Calcium, but what is this? Phosphorus. We're going to have carbon. We're going to have sodium. We're going to have magnesium. Organic and water varies with age of deposit, hardness, and locations. We're going to have all kinds of minerals, just like a rock, but with the mature calculus, uh, is really mostly inorganic. So the older it is, the harder it becomes and the less water. So you will know when you see this older calculus, it's going to feel different and it's going to be way more difficult to remove. The rest is organic and water. We also have trace elements, and we have them right here: zinc, strontium, manganese, iron, potassium, silicon, and fluorine. Now for the fluoride in calculus. So there's like kind of a paradox in terms of fluoride in the calculus. We're going to be learning that certain things have a lot of fluoride. And one of these things is tea. Tea has a good amount concentration of fluoride. So I'm going to go back to this. So the concentration of fluoride is influenced by the fluoridated water intake and fluoride exposures. So you will have also fluoride in calculus, higher levels in subgingival calculus, and cemento has a higher content on fluoride than enamel. And the fluoride will be binding to the hydroxyapatite crystals, and it will be reducing demineralization. So even the fluoride in the calculus is anti-karyogenic, which doesn't mean that it's anti-infection, right? So if we still have those big rocks, the patient might not have a tendency to develop cavities in those areas, but the calculus will do its thing, right? And just create a lot of destruction in the underneath where the bacteria are colonizing. Now, the calculus crystals. Uh, Two-thirds of inorganic material, they're going to create the crystalline structure. The mineralization consists of crystal formation, namely hydroxyapatite. The hydroxyapatite will be compound in the enamel, octocalcium phosphate with loctite and broshite. These crystals form in the intercellular matrix and in the bacteria. So we have calculus crystals forming. And this hydroxyapatite that is so, so good for the teeth is what makes your enamel nice and strong, right? We're learning this. That's the one that becomes fluorapatite, even stronger. So, something that creates your enamel, that gives the enamel that wonderful quality of being the hardest substance in the body, will give the chunks of calculus the quality of being the hardest pieces of calculus to remove. These crystals have different proportions of calcium and phosphate with other ions, and this is the list of the ions. I just realized that my chimes, they're probably loud. I apologize. I'm really excited that there's breeze. I'm just so happy. Today has been a hot one, guys. Okay, now calculus versus teeth and bone. Now let's talk about this comparison. Dental enamel contains 95 to 97% of inorganic salts. So this is what we're talking about. Most highly mineralized tissue in the body. So dental enamel wins, harder than bone. Dentin has 65% of inorganic salt. Cement on a bone, 45 to 70%. And the mature calculus, guys, contains 70 to 80% of inorganic content. Okay, so we're seeing here how hard this substance can be. So 70 to 80% of inorganic content. And I'm going to ask you to please remember this for your exams and quizzes. Organic content consists of various types of non-vital microorganisms. What do we mean by non-vital? They're dead. They're the skeletons of all microorganisms. We have old cells too, dead cells, leukocytes, and mucin. Okay, so all of this is the organic content of calculus. And then we also have some lipids and some protein. Now, the formation of calculus in 3 steps, and this is going to be overlapping a little bit with our last lesson. We have pellicle formation, we have biofilm formation, and then we have the mineralization. The source of the elements for the mineralization is not the same for sub and supracalculus. Let's remember this. For supra, your saliva and the minerals in your saliva. For sub, the intraclavicular fluids, okay, is the fluids that come out of the tissue around the calculus and the tissue in the bottom of the sulcus or around the sulcus of the tooth. The early calculus formation. Early calculus, I think by now you're kind of seeing that the little bubbles, the cocci, are always first. Those are the most ubiquitous microorganisms in our body. The little bubble bacteria, the cocci. Second, we're going to have our rods, our little hot dogs. By the fifth day, filamentous microorganisms provide the matrix for the deposition of minerals. So we also have a matrix, and it's provided by the filamentous microorganisms. Now, the way the calculus starts forming, it starts from the inside out, which always surprises me, right? It always surprises me because you'd be thinking that it will be hardening from the outside in, kind of like a cake. But no, it starts from the inside out, and these areas of mineralization are called foci. Um, and let the singular will be focus. It's the focus the focus on mineralization, foci. 24 to 72 hours, more mineralization foci develop close to the tooth surface, and eventually the calcium phosphate crystals directly bond to enamel and cementum apatite crystals. Okay, so first we're going to have our biofilm, our pellicle, then biofilm, then the formation of the calculus, early calculus, your bubbles and your rods. And then when the filamentous organisms come, you can start forming that calculus matrix. Then we have the foci, and then we have the crystals as the last step. Now, for the mechanisms of mineralization, we have salivary flow, salivary supersaturation with calcium phosphate. So some people actually have thicker saliva and inhibitors or promoters of formation. Supersaturation would be a driving force for mineralization. Urea and silicon would be a promoter of mineralization, and these are inhibitors, pyrophosphates and zinc salts. Beta blockers, diuretics, and anticholinergics, they help us with reduced levels of calculus. Now, I want to do it. I want to give you a disclaimer for this. Some of these drugs will give the patient a dry mouth, so they kind of help them not having so many minerals in their saliva, but then they make their mouth dry. So one thing for the other. So the actual mechanism is not meant to mineralize, but the xerostomia might help it mineralize faster, okay? So talking about supersaturation, you're thinking of a lot of salt in 2 gallons of water compared to a lot of salt in 1 glass of water, right? So it could be the same amount of minerals, but when you reduce the amount of water, it becomes a more thick and more sticky liquid that obviously will have more tendency to form calculus. Now, the structure of calculus forms in layers that run parallel with the tooth structure. The layers are separated by a line, so they are absolute total layers. This line appears to be a pellicle that was deposited over the previous calculus. These lines can be called incremental lines. Please remember these incremental lines are in your national boards. I'm giving you 1 point in your national boards already. These lines form around the tooth supragingivally and irregularly from crown to apex subgingivally. Okay, so we're going to have layers, and this is much like just like wood, like the carbon ring situation, right? So the line in between will be pellicle that forms over the previous layer. The structure of calculus, the surface will be rough. Outer surface of biofilm of subgingival calculus is in contact with the diseased pocket epithelial lining and is inaccessible. Types of deposits, you're going to find each one of these: crusty, spiny, nodular, ledge or ring formation. You can have a ring all around the tooth. Thin, smooth veneers, those are the ones sometimes that are hard to detect. Finger and fern-like, and supra on subgingival deposits. So you can have calculus that is subgingival, and then you can have calculus coming out of the subgingival calculus, which will be a combo. So this is calculus in an anterior. So if we were together, I will have you tell me what else did you see that's a problem here. So this patient has a very, very advanced recession situation here. So this is really a bad combination, guys. Um, so the patient, you can tell there's something irritating on the sides, which is probably calculus. Then you have something irritating in the bottom. The patient has lost already about 6 to 7 millimeters of tooth. And then if I had you in front of me, if you saw this inflammation here, what would you think? Hmm, there'll be calculus in there, and there'll be more bone loss. So there's a good chance that this tooth will be mobile. Okay, so this is another phase of how calculus can look on the anteriors. Formation time. The average number of days needed for the soft deposits to change to the mature mineralized stage is 12 days. Mineralization can begin as early as 24 or 48 hours, and formation time depends on genetic variation, diet, and biofilm control. Attachment of calculus. Where does it stick to? Attaches to acquired pellicle, superficial, no interlocking. So we know that our pellicle is all pretty much things that are delicious and attractive to microorganisms. Attachment to minute irregularities, mechanical locking into undercuts. So these will be your sharpest fibers. I'm not showing you right now what they look like, but we know that calculus will attach to anything that's rough. And under the gum, they're going to attach to rough areas under the gum, subgingivally. And then we have attachment by direct contact between calcified inner cellular matrix and tooth surface. Interlocking of inorganic crystals with the mineralizing of biofilm. So let's look at this. So we have your sharpest fibers, which are here and here, okay? So we have these little fibers that are gonna be a real good place for the calculus to attach to, okay? And obviously, if the periodontal ligament is here, there's no calculus in there. And the calculus is going to happen when there's an open space. Okay, so you're going to see the sharpest fibers, and if you're starting to have a little bit of bone loss here, you're going to see the little chunk of calculus attaching here, and then it makes a real nice house for the bacteria. And we start losing ligaments while the calculus is attaching to the sharpest fibers. So just remember where the sharpest fibers are. So they're going to be onto the cementum of the tooth, and they're going to be into the alveolar bone. So that's where the periodontal ligament attaches to. It's designed by nature to attach the ligament. But once the ligament is not there, it will be attractive to calculus formation too. Now, the last couple of slides about calculus, we have more buildup of calculus because of certain medication, either because of the composition of the medication or because of the side effect of xerostomia. Mentally handicapped or even tooth-fed patients will develop heavy calculus. So our saliva, beautiful, helpful, just precious saliva helps us prevent calculus. It helps us form it, but it also helps us prevent it. So you're going to see these situations, if you ever see head and neck radiation patients, where their salivary flow is highly impaired. And you're going to see that these patients have lots of calculus and lots of decay. And this could happen in just a couple of months, okay? So this is like a very nuanced balance for our saliva. So these patients that are mentally handicapped, they're drooling a lot. Um, then they will have too much saliva, and the saliva is going to puddle, right? But on the other hand, if you don't have enough saliva, it becomes too concentrated. It's just crazy. Just very, very delicate balance. And the tooth-fed patients, they are not using their salivary flow to eat, so the saliva is not going to be flowing as in an optimal manner. Calculus formation is related to saliva with high calcium and phosphate ions, lower calcium to phosphate ratio in supra, so you will have more calcium to phosphate ratio in supra, meaning that is almost the same, calcium and phosphate. Now for the prevention of calculus, biofilm control, professional periodontal therapy. So that will be us taking care of the patient and removing it so that the tissue can breathe and we can take that home away from the harmful bacteria. And chemotherapeutic agents, these are two that are pretty good for calculus removal, although triclosan isn't something that we use often because it causes allergies. But pyrophosphates and triclosan are indicated for calculus removal at home. Okay, so I hope you enjoyed this lecture and just use it as a reference. I'm gonna post your assignment now, and I hope you have a wonderful weekend. Thank you for your time and your patience, and I will see you on Thursday. We have our fantastic Sonicare presentation. We're gonna learn so much. These brushes are wonderful, and they also help you remove calculus before the calculus takes possession. So I'm really excited that we're gonna have Miss Oseguera present to us, and I will see you on Thursday. Please make sure that you complete your homework, and can't wait to see you again, you guys. Have a wonderful night and a nice weekend. Bye.